Welcome. Today, we're diving into a condition that can seriously impact the urinary system: ureteral trauma. The ureters, these vital tubes, are responsible for transporting urine from the kidneys to the bladder. When they're injured, it can lead to a cascade of complications. Join us as we explore the causes, symptoms, diagnosis, and treatment of this potentially life-altering condition. So, what causes ureteral trauma? The causes can be broadly categorized as external and internal. External trauma often stems from blunt or penetrating injuries. Think car accidents, falls from significant heights, or gunshot wounds. Penetrating injuries are generally more severe and more easily diagnosed. Internal injuries are often iatrogenic, meaning they occur as a result of medical procedures. These procedures might include ureteroscopy, lithotripsy for kidney stones, or even surgeries in the abdomen or pelvis, such as hysterectomies or colorectal resections. The proximity of the ureters to other organs makes them vulnerable during these operations. Let's examine the pathophysiology, or how the injury affects the body. When a ureter is injured, the disruption in the normal flow of urine can have significant consequences. Urine can leak out of the ureter, a process known as extravasation. This leakage can lead to inflammation, infection, and the formation of scar tissue. Over time, this scar tissue can cause strictures, or narrowings, in the ureter, further obstructing urine flow. If left untreated, the backflow of urine can cause hydronephrosis, which is the swelling of the kidney due to retained urine, potentially leading to kidney damage and even renal failure. Understanding who is at risk is crucial. Ureteral trauma is a relatively rare condition. Iatrogenic injuries are actually the most common cause of ureteral injuries, especially during gynecological procedures. The incidence varies depending on the specific type of surgery performed and the surgeon's experience. Penetrating trauma has a high chance of causing ureteral trauma. The epidemiology will depend on both the local injury rates of penetrating trauma and the surgical practice of the surgeons. Knowledge of these trends can improve outcomes. How does ureteral trauma present itself? The signs and symptoms can vary depending on the severity and location of the injury. Some individuals may experience flank pain or pain in the side of the abdomen. Blood in the urine, known as hematuria, is another common finding. Fever can indicate an infection related to urine leakage. In some cases, especially with minor injuries or delayed diagnosis, the symptoms may be subtle and non-specific, like general abdominal discomfort. It is crucial to consider ureteral injury in patients with recent trauma or surgery who present with these symptoms. Prompt and accurate diagnosis is critical. A number of imaging techniques can help identify ureteral injuries. A CT scan with intravenous contrast is often the first-line imaging modality. This allows visualization of the ureters, the surrounding tissues, and any urine leakage. A retrograde pyelogram, which involves injecting contrast dye directly into the ureter via a catheter, can also be used to pinpoint the location and extent of the injury. Ultrasound may be useful to identify hydronephrosis, though it isn't always good at identifying the location or cause. The diagnostic approach depends on the clinical scenario and the suspected mechanism of injury. Ureteral injuries can be classified based on the mechanism, location, and severity. The American Association for the Surgery of Trauma, or AST, has a grading scale that ranges from grade I to grade V. Grade I involves contusion or hematoma of the ureter without laceration. Grade I involves laceration of less than 50% of the ureteral diameter. Grade A2 involves laceration of greater than 50% of the ureteral diameter. Grade IV involves complete transection of the ureter, and Grade V involves avulsion of the ureter, meaning it's separated from the kidney or bladder. Accurate classification helps guide treatment decisions. Treatment strategies for ureteral trauma vary depending on the severity and timing of the diagnosis. Minor injuries, such as contusions, may be managed conservatively with observation and a ureteral stent to support healing. More severe injuries, such as lacerations or complete transections, often require surgical repair. Surgical options include primary repair, where the ends of the ureter are sewn back together, ureterostomy, which involves removing a damaged section and reattaching the healthy ends, ureteral reimplantation, which involves reconnecting the ureter to the bladder at a different location, or, in extreme cases, urinary diversion, such as a nephrostomy tube or ileal conduit. The goal is to restore proper urine flow and prevent long-term complications. Preventing ureteral trauma, especially iatrogenic injuries, is key. During surgical procedures, meticulous surgical technique, careful dissection, and thorough knowledge of anatomical relationships are essential. Identifying and protecting the ureters during surgery, particularly in complex cases, can help minimize the risk of injury. Preoperative imaging and planning can be helpful in certain situations. For external trauma, preventative measures to reduce accidents, such as safe driving practices, can help lower the incidence. The prognosis for ureteral trauma depends on several factors, including the severity of the injury, the time to diagnosis, and the effectiveness of treatment. Early diagnosis and prompt treatment generally lead to better outcomes and a lower risk of long-term complications. Recent advances include minimally invasive surgical techniques for ureteral repair, such as laparoscopic and robotic-assisted surgery, which offer smaller incisions, less pain, and faster recovery times. Research continues to focus on improving diagnostic accuracy and developing new strategies to prevent and manage ureteral trauma, with the goal of preserving kidney function and improving patient outcomes. Thank you for joining us today.